Hello all, today we will study about acute rheumatic fever. Acute rheumatic fever is a multisystem disease and it's due to autoimmune reaction to infection with group A streptococcus. Epidemiology, usually seen in children 5 to 15 years old, and recurrent rheumatic fever may be seen in adolescents and young adults. Risk factors. Risk factors for exposure to group A streptococcus: overcrowded living conditions, poverty, rural area, urban slum. Other risk factors: asymptomatic infection, failure to seek healthcare for sore throat, inadequate diagnosis and treatment of streptococcal pharyngitis, treatment failure. Then inherited susceptibility, female gender, poor access to healthcare, poor delivery of secondary prophylaxis, asymptomatic or undiagnosed rheumatic fever that can predispose to recurrent acute rheumatic fever and rheumatic heart disease. Lack of medication, lack of cardiac surgical facility can predispose to more complications, heart failure, disability, death. Pathogenesis. It is triggered by immune-mediated delayed response to infection with group A streptococci, which have antigens that cross-react with cardiac myosin and sarcolemmal membrane proteins. Antibodies against streptococcal antigens cause inflammation in endocardium, myocardium, pericardium, joints and skin. Clinical features. Usually a latent period of about 3 weeks or 1 to 5 weeks will be there after the episode of streptococcal pharyngitis. And for chorea and carditis, it can occur about 6 months after the episode of streptococcal pharyngitis. And it is a multisystem disorder and usually presents with fever, anorexia, lethargy. Revise John's criteria for rheumatic fever. There are major manifestations, minor manifestations, and supporting evidence of preceding streptococcal infection. Major manifestations: carditis, polyarthritis, chorea, erythema marginatum, subcutaneous nodules. Minor manifestations: fever, arthralgia, raised ESR or CRP, previous history of rheumatic fever, leukocytosis, first degree heart block. Then supporting evidence of preceding streptococcal infection. They are recent scarlet fever, raised ASO or other streptococcal antibody titer, positive throat culture. So for diagnosis of acute rheumatic fever, more than or equal to 2 major manifestations or 1 major manifestation plus more than or equal to 2 minor manifestation with evidence of preceding streptococcal infection should be there. In isolated chorea or pancreatitis, presumptive diagnosis of acute rheumatic fever can be made without evidence of streptococcal infection if other causes have been excluded. In established rheumatic heart disease or prior rheumatic fever, a diagnosis of acute rheumatic fever can be made based only on multiple minor criteria and evidence of preceding group A streptococcal pharyngitis. So coming to carditis, usually pancarditis occurs, that is endocardium, myocardium and pericardium are involved. Breathlessness occurs due to heart failure or pericardial effusion. There will be palpitations. There will be chest pain due to pericarditis and pancarditis. Tachycardia, cardiomegaly, new or changed murmurs. That is soft systolic murmur occurs in mitral regurgitation. Soft mid-diastolic murmur, that is Caricum's murmur, occurs due to valvulitis with nodules on mitral valve leaflets. The pericarditis causes pericardial friction rub and precordial tenderness, and ECG may show STT changes, and also ECG shows conduction defect if there is AV block, and if there is AV block, patient may present with syncope. Next, polyarthritis. It presents as acute painful asymmetric and migratory inflammation of large joints, usually affects knees, ankles, elbows, wrists, and the joints are involved in quick succession and presents as red, swollen and tender joints. Next, Sydenham's chorea. It is also called St. Vitus dance. It's a late neurological manifestation and appears about 3 months after the episode of acute rheumatic fever. By that time, all other signs may have disappeared. It is more seen in females. And first there will be emotional lability. Next, there can be purposeless involuntary coriform movements of hands, feet and face. And speech may be explosive and halting, and spontaneous recovery within a few months occurs. Next, erythema marginatum. It starts as red macules and fade at the center, and that remain red at the edges, causing red rings, and later they coalesce or overlap, usually seen in trunk and proximal extremities. Next, subcutaneous nodules. They are small, 0.5 to 2 centimeter, firm, painless, usually seen in extensor surfaces of bones or tendons, usually appear more than 3 weeks after the onset of other manifestations. Next, coming to investigations. First, evidence of systemic illness by leukocytosis or raised ESR or CRP. Evidence of preceding streptococcal infection, that is by throat swab culture, which shows group A beta hemolytic streptococci, and also the culture can be taken from family members and contacts. ASO, that is anti-streptolysin O antibody. If it is abnormal, it is more than 200 units in adults and more than 300 units in children is abnormal. Evidence of carditis, that is chest X-ray shows cardiomegaly, pulmonary congestion. ECG shows first and second degree AV block, features of pericarditis, T inversion, reduction in QRS voltages. And echo shows mitral regurgitation, dilatation of mitral annulus or prolapse of anterior mitral valve leaflets or aortic regurgitation if present and pericardial effusion if present. Next, coming to management. Management is to limit cardiac damage and relieve symptoms. First, bed rest. It lessens joint pain and reduces workload of heart, and patient can later return to normal activity, but for the strenuous activity to be avoided in those who had carditis. Next, treatment of cardiac failure, either medical treatment or valve replacement surgical treatment may be needed. Next, antibiotics. So, the treatment is benzylpenicillin 1.2 million units IM stat or oral phenoxybenzylpenicillin 250 mg 4 times daily for 10 days. If penicillin allergy is there, then we can give erythromycin or cephalosporin. So, next, long-term prophylaxis. Either oral phenoxymethylpenicillin or benzylpenicillin can be used. Oral phenoxymethylpenicillin 250 mg twice daily or benzylpenicillin 1.2 million units intramuscular monthly can be used. If penicillin allergy is there, erythromycin or sulfadicin can be used. Long-term prophylaxis should be continued till the age of 21 or till 5 years after last episode of acute rheumatic fever, whichever is longer. And in those with residual heart disease, long-term prophylaxis has to be continued till 40 years or 10 years after last episode, whichever is longer. Then aspirin helps to relieve symptoms of arthritis. Usually dose is 60 to 100 milligram per kg per day divided into 6 doses. Then glucocorticoids, it helps in symptom relief and usually given in carditis and severe arthritis. Dose prednisolone 1 to 2 mg per kg per day is the dose. Thank you.